My name's Nick Majerison. Welcome to Top Med Talk. In this piece, you're going to hear Desiree Chappell speaking with Allan Beck, the Chief Executive Officer of the Baylor Orthopedic and Spine Hospital at Arlington. It's a conference highlight, and it's taken from our coverage of the American College of Perioperative Medicine Interdisciplinary Conference on Value-Based Care for Orthopedics. Have a listen.
Top Med Talk.
So, Allan, can you give us a little bit about your background and how you are really, as a CEO, overseeing these different types of value-based care programs and how it's affecting the care at your facility?
No, absolutely. So I've been CEO of the hospital here since its inception about 8 years ago. First CEO position, I had previous positions as Chief Nursing Officer. Our facility is a little different. It was a de novo facility, but it has one main orthopedic group, and I think similar to the Rothman Institute, the other facilities is where there's a lot more alignment when you have that one group. There's a lot more successes there. The main thing, I think, came a couple of years ago that was our motivator was with some readmission challenges we had. Our patients had great outcomes, but we did have a little bit of spike in readmissions, and we actually had a penalty on the readmission side, and that was the first motivator. When we looked at that and we got the information, and it was stuff, had nothing to do with the surgery, maybe it was constipation 30, 60 days out. After we went through all of our phases of anger, denial, and different things, we realized we have to own it and manage it. So we started doing an optimization program and managing those patients a little bit more. And then a couple years ago, our physician practice got involved with the BPCI project. That is a voluntary project, and it was around the practice, but we partnered with them at the facility level. And we kind of went off that successes that we had in the readmissions, working through that. Started enhancing our patient optimization program and managing our post-discharge, really sharing the information, getting a lot of the information from BPCI. Our physicians didn't see that in the past. So now they can really see, wow, what is that post-acute spend? How many of my patients are really going to inpatient rehab and going to SNFs? And a lot of them, when we asked that question before, we said, what do you think your percentage is? And they had no idea. So I think we had a lot of successes just sharing that information with them.
That's fantastic. Before we leave, the big takeaway from the meeting this weekend.
A lot of it is, like Dr. Pond mentioned, I think a lot of it is validation. We have a great team to kind of brag on them, but a lot of it is validation of kind of what we're doing. I think there are some pieces on the optimization. We're about 1 year into it where we actually put hard stops in place where we won't do those surgeries, and I think here we are actually probably better define those. Hemoglobin 1Cs, they talk about a lot, and it's been a little difficult to manage it, but how can we manage it in a tighter time frame? So looking at fructosamine, looking at if we can manage it with a patient's blood sugar logs for a shorter period of time, and what level should that be? So we got some information. We were looking at blood sugars of 200. Now we might tighten that up to 180. So I think it is kind of fine-tuning. It's validating some, but it's also fine-tuning some of the processes that we have.
And I actually do have one more question I'm dying to ask you. As a nurse, I think that sometimes your perspective on things are a little bit expanded. What are you guys doing for care coordination? Are you using a nurse for that, or different specialties? What does your coordination path look like?
Yeah, absolutely. Well, I think the big thing is we really started pushing and enhancing our pre-med testing process. A couple of years ago, it was the neglected department, and we really enhanced that. We moved it. We gave them more space. We put more resources in there. So looking at the early side, making sure our patients are prepared for surgery and optimizing them. Also enhancing our education, making it the total joint class mandatory, and then adding spine to that also. Then on the back side, realizing that we have to own that episode for 30, 60, 90 plus days now. We started a post-discharge management process where we actually have our registered nurse contacting them at different intervals, usually within 24 to 48 hours, 7 days, 14 days, 30 days, 60 days, 90 days. The contacts are a little bit less invasive as it goes down, so it's not annoying the patient, but just a touch point, but also letting them know that there's a resource for them to call the hospital or call the nurse triage line. So that's been in place for almost a year now, and I think that's helped out a lot too.
Top Med Talk.
Thanks for downloading Top Med Talk. Quick reminder, please subscribe to us, and of course, please connect with us on social media. We've got a Twitter account, we've got a Facebook account, we've got a LinkedIn account, we've got every single possible social media you could imagine. Pretty much. I'm sure there's a new one just been invented that we've yet to cover yet. But have a little look and follow us on social media, reach out and connect, and email us contact@topmedtalk.com.